In the next 6 minutes and 40 seconds, if you pay attention to what I'm telling you, I guarantee at some point in your career, you're going to save a life. Not a lot of things you can say that you're going to invest 6 minutes and 40 seconds of your time and make a tremendous difference in the outcome of your patient. And I don't care where you work, if it is the largest tertiary care center or a community hospital where you have 10 beds, this will apply to every one of you as a practitioner. Now the title is a long one. Identifying patients at early risk of decompensation when admitted to an ICU setting, but really it boils down to, do you remember who you admitted last night? Did somebody call you and say, oh, by the way, hey Jack, I hate to tell you, your patient crashed on the floor last night. How many times do you actually get feedback on your admitted patients? We don't get it often enough. We don't talk to our hospitalists often enough, but what happened? Do you look up every one of your patients when they're admitted? Find out what was their clinical course in the hospital. Did I get it right? One of the most important decisions that you make is what setting are you admitting that patient to. You set them up for failure if they're an ICU patient waiting to happen and you do not admit them there. Part of the problem, if you talk to your intensivist, they want ICU resources for patients that need them now. Patients that need ICU resources now. They're on a ventilator, they're on pressors, I get it. They need an ICU resource now. Try to convince them of who needs ICU resources in 4 hours. That's a much different discussion when they have one bed. So how do you do that? Let's go through some of that. And secondly, how do you know they didn't crash a few hours later? So we need to start asking a different question. Stop asking, do they really need an ICU bed? The question you ask is, what puts them at risk for not giving them an ICU bed? That's the question you ask, and that's what you discuss with your hospitalist, faculty medicine person that is admitting that patient to a non-ICU bed. Two really important points. Number one, the hospitalist never saw that patient when they came in. They didn't see that patient critically ill. It's 2 hours later, they look a lot better, they're falsely reassured. Number two, you probably don't work in a non-ICU setting on the floors. You don't know the nursing resources. You don't have any idea what the resources are for that code team that comes to the bedside at 3 in the morning. I've worked there. I can guarantee you it is the most chaotic, inefficient, worst way to run a rapid response or a code in the entire hospital. It is far different from the emergency department, and that is not a knock on the hospitalist. That's resources. That is being trained to know what to do in that situation. So, and the patient doesn't know any better. They can't ask to go to the ICU. So a couple things to remember, very important. I'm going to tell you this, and I'm going to tell you again at the end. Your choice of admission unit matters. It makes a difference. Your mortality goes up for that patient if they have an intermediate stop from the ED to the ICU. Hospital length of stay. Your hospital cares about this. Every one of these patients, they're going to at least double, if not triple, their length of stay. Cost goes up. Now you have unreimbursed days and patients that are going to be stuck in your ICU. Number one cause of these patients, respiratory compromise. It's the vital sign we never pay any attention to, the respiratory rate. How often does your nurse come to you and say, Dr. Perkins, your respiratory rate for your patient going to the floor is 66 or 32 or 24, whatever. Nobody comes and tells you that. They document it, then they send them upstairs. The respiratory rate is really not paid attention to. And think about your floor resources. Is that something that is going to go well when the respiratory rate is climbing as they go up to the floor? Severe sepsis. We'll get back into this in a minute. Dr. Winters talked on this a little bit yesterday. It is the disease process we do not appreciate. And finally, the disease process that incorporates both of these, pneumonia, the perfect storm for a rapid response or a code waiting to happen. So we have a great tool for evaluating severity of illness when you walk in the door. The ESI is validated. It works really well in terms of you need to be at the bedside right now. But we have absolutely nothing when they leave. Zero. Not a thing in the world to identify who's going to crash in the next couple of hours when they go to the floor, when you and the admitting team got it wrong and misidentified this patient as being at high risk of crashing. The first disease process that we need to talk about is severe sepsis. The problem is it is an enormous umbrella of diseases. So if you think about it, We admit STEMI to this cardiac intensive care unit. Nobody thinks about that, and the mortality is only 5%. We're going to admit a stroke to the neuro ICU. Mortality is 10%. Severe sepsis, if you have 3 to 4 qualifiers, 20% mortality. Why would you admit that patient to a non-ICU setting? It should be for the patients not only who need the ICU, for the potential to be the sickest patient in the hospital in the next couple of hours. So if you look at severe sepsis, it's very difficult to identify. There's 9 different qualifiers, a lot of which are very subtle. Mortality rises with each qualifier, but it's still the same umbrella of severe sepsis. Classic patient waiting to crump. This comes out of the Surviving Sepsis campaign, but it's also how CMS is defining severe sepsis. All you need is 1 qualifier, but that's not the point I'm trying to impress upon you. What I'm impressing upon you is if you have a patient that starts adding these up, they're hypoxic, they've got a lactate of 2.5, they had a single episode of hypotension, maybe a little acute kidney injury, now you have 4 qualifiers, now the mortality is at least 20%. Why would you send them to a non-ICU setting? They are on a continuum and they are headed to septic shock, and it will happen on the floor at 3 in the morning. You can't admit all of these patients to the ICU. It's not possible. You need to think about your hospital resources. Codes and rapid responses are bad for patients, but this is where you talk to the hospitalist. Clearly, come down, let's discuss with the patient. You didn't see them when they came in, but I don't understand your nursing resources at 3 in the morning. Let's talk about where is the best place for this patient to go in this hospital today with this particular patient. Pneumonia, this is the other one you really, really have to pay attention to. Very, very tricky, and can underestimate the severity of badness that's going to happen for this patient on the floor. Severe community-acquired pneumonia is what we're talking about. And if you don't admit severe community-acquired pneumonia to an ICU setting, you're asking for bad things to go wrong. PSI and CURB 65 are not designed for identifying who goes to the ICU. They are identifying for who goes home. If you're going to identify for who goes to the ICU, you need to use the severe community-acquired pneumonia criteria. There's 9 qualifiers. There's a lot of overlap with severe sepsis. You can look this up. Pull it up. It's 2007 Infectious Disease Society of America and American Thoracic Society. It makes sense. It's validated. Tachypnea, multilobar infiltrates, confusion, hypoxia, BUN greater than 20, leukopenia, thrombocytopenia, hypothermia, and hypotension. Some are subtle. If you have 3, the mortality is 30%. Why would you send that patient to a non-ICU setting? Wrapping this up. If you paid attention and you're taking this back to your hospital, this really is important. That couple minutes that you send the patient to a non-ICU setting, really think about it. Is this the patient that's going to crash in the next couple hours? And is there something we can do about that? Each hospital is different, but there's really a couple common themes. No matter which hospital you're in, severe sepsis, respiratory compromise, and above all, pneumonia does not do well in a non-ICU setting in certain patients. Really think about it. And 3 is the magic number for severe community-acquired pneumonia and also for severe sepsis, where mortality hits about 20%. Thank you for your time.